Thank you, sir. And this is very wonderful and lucid presentation on the wake-up stroke. So now our next next talk will be autoimmune encephalitis, diagnostic and therapeutic dilemma by Dr. Chaitanya, JSK, sir.
Good evening, everyone. So today my topic is autoimmune encephalitis. This is one group of patients whom we all think we don't know what's happening with them in our ICU. So it has evolved to become one of the most common form of non-infectious encephalopathies or encephalitis patients whom we are seeing day in and day out. In last 15 years, with increasing technology and increasing discovery of newer antibodies, now all those group of patients who are left undiagnosed as idiopathic are falling into this category, and now its incidence and prevalence is almost matching infectious etiologies. Common targets these patients we have are the neural epitopes on synapses or the intracellular antigens. Intracellular antigens are what we have been seeing for quite some time. All the neural epitopes are ones which are being discovered recently. Their presentation will be very wide. They can be presenting with refractory seizures. They can be having neuropsychiatric illnesses. They can have cryptogenic encephalitis. They can present with atypical movement disorders and many autonomic disturbances. It is very important to diagnose them early and treat them because early diagnosis and treatment impacts his prognosis. And this is one other group of patients in neurology where if you miss a diagnosis, they have very high chance of relapse of the same problem. So it is very essential to have an eye to look for this group of patients. So pathology, as you say, the surface antibody targets, which are predominantly anti-NMDA, anti-GAD, anti-GABA, anti-VGKC, which was initially labeled anti-VGKC, but now with newer discovery, they are able to identify them as LG1 and Casper. So how they cause symptoms are either they internalize the NMDA receptors, prevent synaptic transmission, or they block GAD transmission or AMPA transmission in the synapses, or as I said, LG1 and Casper anti-VGKC antibodies. Intracellular are predominantly paraneoplastic manifestations, usually with solid masses. As I just briefly told, they have very diverse presentations. Syndromic presentation, I mean, based on the neuronal antibody which we are identifying, presentation can be syndromic by group of symptoms which are involved. So when do we suspect autoimmune encephalitis? As I said, any new onset psychiatric episodes, still we know that prevalence of psychiatric illness and new onset psychiatric illness is more common than autoimmune encephalitis. But any new onset psychiatric disease who are responding abnormally to your antipsychotic medications, there is high, they have noted that there is high instance of neuroleptic malignant syndrome in this group of patients. Patients who rapidly have cognitive decline, those patients who have status, who present to us with status epilepticus, and which where we are not able to find a common trigger what has caused this status epilepticus. New movement disorders, especially in the younger age groups. We all know for movement disorders in young age, the common presentation is drugs. And if we are able to rule them out, and then we identify that we don't find a cause, we should have autoimmune encephalitis in one of our differentials. If there is progressive deterioration of the patient's symptoms or the imaging, in spite of your treatment or in your management of your differentials, we should think of autoimmune encephalitis. Those patients presenting with this group of symptoms following some acute infection or an acute illness or starting of immunosuppression, there we'll need to think of autoimmune. Abnormal EEGs, abnormal MRIs, or abnormal CSF pathologies like a presence of some signs of inflammatory changes. All these should lead us to think of autoimmune encephalitis. So in 2021, there is a publication where to simplify diagnosis or to simplify catching up these cases, they looked at how we classify these patients. So one is by anatomical classification. Anatomical classification is based on which area is involved. We can localize that based on the symptoms, based on our symptomatic localization or MRI or EEG. By that we label them as either limbic or brainstem or cortical or subcortical or diencephalic. Then serological classification, that is based on your investigations, based on identifying antigens, whether they are paraneoplastic ones or the surface epitopes, or sometimes even seronegative autoimmune encephalitis. Then comes the etiology, either it is idiopathic, paraneoplastic, or it is coming post-infectious. A newer class, which we are often seeing now with increasing advent of monoclonal antibody usage in cancer, that is immune checkpoint inhibitors. These are another group of patients who are often coming with autoimmune encephalitis. So as I said, if you see the whole list you go through, it will be a similar repetition, predominantly neuropsychiatric manifestations, cognitive declines, new onset seizures or status epilepticus, or sometimes even peripheral neuropathies. So all these things, and autoimmune dysfunctions is one other thing which will bring the patients to ICU. So these are group of syndromes which you, when you try to focus on these syndromes, you will be able to request appropriate tests and then localize on the syndromes. So I'll just rush through two main syndromes which we often see. Anti-NMDA receptor antibody disease, where they usually follow a viral prototype. It usually has an acute or a subacute presentation. Initially, they come with some psychiatric illness, but then they start developing movement disorders. And as well as the course progresses, patients develop unconsciousness or severe autonomic dysfunction. That's when they land to us into the ICU. When you are able to diagnose it early, at least 50 to 55% of them can have very good response within their first treatment. And many of them tend to have relapse. Most of these patients are young females, and we should also screen them to see if there are ovarian teratomas, which have very high correlation in their diagnosis. Anti-LG1 encephalitis, this has little prolonged presentation, like it can present subacute to sometimes chronic. Many of the times these group of patients get missed as neurodegenerative disorders. They have predominant movement disorders, especially faciobrachial dystonic seizures, and later they show cognitive decline, and then at the end with autonomic dysfunction. Most of the times they are missed in the early stages, but when picked up they show very good response to treatment. And this is one group where you should not rely on CSF antibodies, you rely on serum antibodies. NMDA receptors, there is more specificity when you look at CSF, but in anti-LG1, a serum LG1 antibodies itself gives you a good specificity to identify the diagnosis. So what are the challenges here? We have very wide spectrum of presentations. MRI may be informative, non-informative. EEG changes are not very specific. We have clinical overlap with many other diseases like infections, nutritional deficiencies, toxins, be it drugs, be it abnormal misusage of drugs or cocaine, etc. There is an entity called seronegative autoimmune encephalitis, and we have long list of diseases which have overlap of these symptoms. So in 2016, Gross et al. Have come up with a simplified algorithm where you can easily identify or we are not misdiagnosing these groups. So it's predominantly these three, where when you meet all three, there is a chance that this is a possible autoimmune encephalitis. So you have a subacute onset presentation with altered mental status or psychiatric symptoms or cognitive decline, and you have this is the clinical syndrome what we are looking at. Second, you need to establish there is some inflammation which is causing this clinical syndrome. You are identifying that by either CSF abnormality or MRI abnormality or a focal CNS findings. Third is a reasonable exclusion of alternative diagnosis. So when you meet these criteria, you can try to start evaluating them or managing them as a possible autoimmune encephalitis patient. Then comes your evaluation, be it MRI, EEG and all. If you have an imaging suspicion, imaging substantiating your diagnosis with changes in the limbic encephalitis, then you label it as definite limbic encephalitis. If you have positive neural antibody matching your syndrome, then it can be labeled as definite antibody positive AIE. But when you have negative antibodies or negative imaging, then it could still be a probable antibody negative autoimmune encephalitis, where you keep your diagnosis open still, but you tend to manage based on severity of their symptoms. So how do you classify their severity? So there have been studies in the initial stages. They used modified Rankin scale to to group them in based on their severity, and now a newer modality called CAS score, clinical assessment in severe encephalitis. So CAS score has found to have very good reliance. It is a 27-point score, which includes all the symptoms which we have discussed, which scores from 0 to 3 for each of them. And based on that, when CAS score is more than 9, it falls into a severe category. MRS of 0 to 2 or less than 2 and CAS less than 9 have good prognosis, and prognosis worsens when they fall into the other side of the score. So just to summarize, you have you need to have a syndrome in mind and then do appropriate imaging, then confirm an inflammatory etiology, and management starts in the second step, but then it doesn't end there. You'll have to, most of these patients have an association with malignancies, so always continue to screen. Sometimes autoimmune encephalitis presentation precedes the malignancy, so they have to continue monitoring them for any malignancy showing up in the later stage. So what blood tests you do? Basically the same as we all discussed now. One, to establish that there is some inflammation going on, you do your routine test. You do your routine test to rule out metabolic syndromes. You rule out to do all your toxin syndromes. You do a CSF analysis. You see for nutritional deficiencies and systemic autoimmune disease. Even lupus can cause encephalopathies like this. So ANA profiles and infectious disease workup. So what to exclude again? So as I said, all these differentials. So somebody presenting with limbic encephalitis, you might be dealing with a viral encephalitis, or somebody who is coming with a subcortical or cortical encephalitis where your EEG is not showing much. These patients might be having something like a lymphoma which is evolving, or they can be having some demyelinating diseases, or your MRI is only showing a post-seizure sequelae. If you're dealing with brainstem encephalitis, you might be dealing with Bickerstaff's encephalitis, or you could be dealing with ODSS. So all these things should be in your mind when you're evaluating, and your the tests or evaluation which you do should have all your differentials in mind. Sometimes even your MRI imaging could be derailing you. So you can see the first part, you see temporal encephalitis, where you might be thinking that there is viral encephalitis going on, or based on your antibody tests, you might be thinking there is an autoimmune encephalitis. But there, when you do a serial MRI, you'll get to know a progressing disease. Then, and this was a biopsy-proven case of astrocytoma. There could be the sequential, all these images which I am showing are metabolic disorders, HIV associated diseases like HIV associated leukoencephalopathy, who have similar presentation. The last one which was showing just a faint hyperintensity there, but there has been gradual worsening in both cognition and motor syndromes, and it was been biopsy proven to have a prion disease or CJD. So what are the red flags where we always go wrong? So you should have these things in mind. So as I said, acute to subacute is what most of them present. So if you have an insidious onset, or the progression is happening over days, there is continuous decline, or if your examination results are not matching what you're finding in the MRI, or you have a normal neuropsychologic test across days of the course, all these are red flags. So as a same way, CSF, when there is no inflammatory change, when you don't find abnormal cells or protein, that's one place where you should think of other diagnosis. And then all these, what we face daily is some random test being done as a blanket. So when we do a serology, previously I think many of us see neurologists asking for anti-TPO antibodies. So previously were anti-TPO antibodies. Now with the advent of all these nuclear antibody autoimmune encephalitis panel of antibodies, we are seeing many of those patients falling into these groups. So anti-TPO is no more encouraged to be done for an encephalopathy. Similarly, where you have low titer positivity of antibodies like anti-GAD or anti-VGKC. Now, there has been statements across Canadian guidelines now that anti-GAD 65 need not be suggested for encephalopathy evaluation because there is high incidence of false positives. Same way, when you have low titer or a strong positivity of serum VGKC, but you don't have positivity with any of these antibodies like anti-LGI, anti-LG1 or anti-Casper, again, anti-VGKC could be a false positive. So knowing all this, you should pinpoint your diagnosis and keep your differentials open still while we manage this patient. There has been a study which is published in JAMA where they looked at 3 centers which are specialized with autoimmune encephalitis. They have looked retrospectively for, I think, 4 years data where they have labeled and treated and then followed up those patients. And they found common reasons for misdiagnosis were overinterpretation of a non-specific antibody, misinterpretation of their symptoms to be neuropsychiatric or neurologic, imagic findings or functional neurological features, or failure by the patients or the doctors to accept that these are all psychiatric origin. Common serology, as I said, anti-GAD65 and anti-VGKC are the common serologies which are misguiding us to the diagnosis. So treatment, once we diagnose, it depends on what antigen we are or what antibody we are localizing it to. Intracellular antibodies, especially paraneoplastic, have bad prognosis, and initial treatment of choice there would be treating the malignancy and drugs like cyclophosphamide or rituximab. So for all patients, when you have a suspicion, when you based on the criteria which I have just told, Gross et al.'s criteria, so parallelly as the treatment, as you evaluate for them for identifying that there are definite cause, you need not wait in treatment. Once you are sure that you have ruled out an infectious etiology, you should be able to start immunomodulator therapy. So first line drugs are steroids, which is a pulse dose of salmeterol up to 1 gram per day, 3 to 5 days is the treatment. If the illness is severe, as I said, based on the MRS score or the CAS score, then you should combine it with IVIG or plasma exchange. There are studies where they delayed initiation of plasma exchange and then they found the recovery rates poorer. So once you start treatment, and you need to assess for the outcome at the end of 2 weeks. And if there is treatment failure or no response to your first line treatment, then you'll have to escalate your second line.
Dr. Chaitanya, can you close in next 1 minute?
Yes, sir. Nah.
Thank you.
So always when we are escalating onto the second level of treatment, always review your diagnosis. So second line of treatment includes rituximab, sometimes cyclophosphamide alone, or if it is paraneoplastic, both together. I think that is the time when further escalation should require a specialist autoimmune and neurologist opinion. Newer drugs like tocilizumab, intrathecal methotrexate, or sometimes even inlepimab. So many monoclonal antibodies which are coming up. These acute treatments should also be followed by maintenance therapies, which could be a monthly IVIG or maintenance dose of steroids. So take home points: early recognition and early initiation of treatment is crucial. We should be able to reasonably exclude the other differential diagnoses, including infections. Always be cautious of misdiagnosis. Monitor your treatment. Review your diagnosis whenever you escalate treatment, and don't forget to screen for malignancies during that episode and also during follow-up. Yeah, thank you.
Thank you, sir, taking us through a very complex miscellaneous topic. Now we are heading for our next